Okay, further into terms, relationship term. Superficial versus deep. Superficial means it's closer to the skin. Deep means it's closer to the bone. So if you have an injury and it's only like skin level, you could say, oh, it's a superficial wound. But if you have an injury and it goes all the way through the soft tissue, that's a much deeper wound. Movement terms, flexion, extension. We'll get into this further when we get into the upper extremity. But flexion usually means that the angle created by a joint is decreasing, right? It can go all the way to like basically a closed leg. Whereas extension means that this angle is increasing. It's getting closer to like 180 degrees, right? As opposed to what we see here is like 90 degrees. Same with this. This angle is getting smaller. Eventually, it'll be real small or it can be extended. Okay, that can apply to the spine as well, as we'll see. Um, Deviation, ulnar deviation, or means that you're turning the hand toward the ulnar side. Radial deviation, you're turning it towards the radial radius. Same with here, plantar flexion, you're flexing it toward the plantar or bottom of the foot. Dorsiflexion, you're angling it toward the dorsal side of the foot. Eversion is an outward movement, sometimes used with ankle imaging, and inversion or varus would be toward the midline of the body or toward the inner rotation. Internal and external. Internal is rotating your hand inward. Lateral would be away, more of a rotation away from the body. Abduction. A good way to remember this is people usually look at add. It's like they're adding it back into the body instead of moving it away. Supination, this is back to up, face up, right? So this is the anterior of the hand, the palm is anterior, so it's like you're facing it up. And pronation is the opposite there. And this is a good one to take a look at again as if we go back to planes. For example, a tilt, right? So it might say that this is going to be our sagittal line, right? Or mid sagittal line. So if they say they wanted the mid sagittal plane to be parallel with the board, that's what that means. Mid sagittal is parallel. And this line too, interpupillary line, they might say. They want that to be perpendicular to the board. So as you can see, right, this is perpendicular to this. As soon as you have angles, like here, it's no longer perpendicular, that's at an angle. As soon as you have angles, that means that you have rotation. Sometimes it's on purpose, sometimes not, and then here, our mid-sagittal plane is no longer parallel with the board. Finally, what I want to say about evaluation criteria, it's important that you always get the anatomy demonstrated. That you are getting as close to possible, considering sometimes pathology, the position that you needed to get, for example, those 45-degree rotations or things like that, that your technique was appropriate to avoid giving the computer inaccurate information. Talk about that more later, and then always use your marker on the correct side of the body. Last, but not least for positioning, usually there's a minimum of 2 projections at 90-degree angles. That does not apply to things like a KUB, for example, unless there's maybe something ingested. So this is a pediatric patient, and it's great. We see they swallowed a coin. It's on the right, it's like kind of right lower quadrant-ish area, maybe kind of in the middle. But is it more anterior or posterior? There's no way to tell unless you take a lateral image. This might be one of those situations where you do take a lateral image. And then back to this. So let's say that you're in a trauma situation and you're trying to get an AP, oblique, and lateral of a wrist, but you cannot get the oblique. Something's happening. The patient just does not want the exam or something like that, or wants to be done with the exam, that sort of thing. Try to always at least get an AP or PA and lateral. That gives 2 dimensions at least if you can't get the oblique. Because as we can see here, right? Okay, we can see the height, their level of both of these, this hardware here. But what does it look like anterior to posterior? There's no way of knowing for that radiologist unless you also grabbed the lateral.